impact survival for people with multiple myeloma. So please join me in welcoming Dr. Kamal Shamoun, who's a fellow with the Hematologic Malignancies and Stem Cell Transplant Program at the University Hospital Seidman Cancer Center in Cleveland, Ohio. Dr. Shamoun.
Good morning. First, I would like to thank ASCO for selecting our study to be presented in this press briefing. No? Okay. So, first, I would like to thank ASCO for selecting this study to be presented in this briefing. Really? Okay. The outcome of patients with multiple myeloma has dramatically improved over the past 30 years. This was mainly due to the increased use of novel agents and to the increased use of autologous stem cell transplantation. However, this gain came at the cost of increased financial toxicity for these patients. Multiple myeloma is now the #1 cancer treated with oral anti-cancer medications. And these medications are often very expensive, and the patient's share of the cost differ widely among patients according to their prescription plan. A study showed that the proportion of treatment costs attributed to medications nearly tripled from 2000 to 2014. Most importantly, another study showed that the out-of-pocket cost for patients with Medicare is significantly higher than patients with other types of insurance. This does not only affect the quality of life for patients, but also affect the adherence to medications. Another study showed that 17% of patients reported delays in their treatment because of cost, 12% reported filling only a part of their prescription because of cost, and 10% reported discontinuation of their treatment because of cost. Based on this, we used the National Cancer Database, which is a hospital-based database that houses data on 70% of cancer patients in the US, to test the hypothesis of whether insurance affects the survival of patients with multiple myeloma. We selected patients diagnosed between the year 2005 and 2014. We looked at the insurance status at diagnosis. We did not have changes in insurance. We looked at the median household income in the patient's zip code area based on the year 2000 US Census. Among other variables like age, gender, race, Charlson-Deyo comorbidity score, transplant status, and treatment facility type. Major limitations of this study are its retrospective nature. There was no disease-specific characteristics, no specific information on the treatment received and the duration of treatment, no information on the subtypes of insurance. We had a total of 117,926 patients. Median age was 67 years, 55% were males, 76% were white, 20% black, 3 of other races. The median follow-up was 30.2 months. There was 54% with Medicare, 36 with a median age of 74 years, 36% with private insurance with a median age of 57, 6% had Medicaid with a median age of 58, 3% were not insured with a median age of 57, and 1% has other government insurance with a median age of 61. When we adjust for patients 65 years and older, and we look at the survival between patients with Medicare and private insurance, we see that there is a survival advantage for patients with private insurance, with a median survival for private insurance patients of 41.9 months compared to 30.8 months for patients with Medicare. The graph on the top left showed the distribution of patients according to their insurance and their median zip code-based household income. Green represents more than 46,000 median household income, pink between 35 and 45.9, blue between 30 and 34.9, and purple less than 30,000. We can see that the proportion of patients with higher proportion of patients with higher income had private insurance. When we plot this on survival, we can clearly see that patients living in higher income areas had survival advantage. The graph on the bottom left showed distribution according to their treatment facility type. Green, patient treated in a network cancer program in a facility that is part of a network program. Pink, patients in academic institutions. Blue, patient treated in comprehensive community centers, and purple, patient treated in smaller community hospitals. Looking at the survival according to their treatment facility type, we can clearly see that patient treated in academic institutions had better survival, followed by patient treated in a hospital part of a network, followed by patient treated in a comprehensive community center, and lastly, patients treated in smaller community hospitals. When putting all these variables in a multivariable analysis that account for age, gender, race, primary versus secondary disease, comorbidities, hospital type, zip code-based median income, and the insurance type, we see that patients from areas with higher median zip code-based income had improved survival. Treatment in an academic setting was associated with survival advantage. Older age and comorbidities, as expected, adversely affected survival. When looking at Medicaid and those without insurance, we saw that privately insured patients had better survival than patients with Medicaid and without insurance on the multivariable analysis. On this adjusted analysis, the difference in survival between Medicare and private insurance was not statistically significant. Thank you.
Okay, thank you so much. As you can see, these are complicated analyses. So I'm going to ask Dr. Catherine Diefenbach to make some additional comments about the significance of the research and interpretation of the findings.
Thank you, Dr. Shamoun, for that really important abstract. So where you live and what insurance you have should not affect the length of time that you survive multiple myeloma, though unfortunately it seems from Dr. Shamoun's study that it does. And Dr. Shamoun analyzed demographic statistics from the National Cancer Database and identified multiple socioeconomic factors, including having private insurance, living in a regionally high-income area, or receiving treatment at certain specific settings, particularly academic practices, as being associated with not only better survival, but longer survival for patients with multiple myeloma. Multiple myeloma affects more than 32,000 people every year, and it is an incurable disease. That means every year 32,000 people are diagnosed with multiple myeloma and generally live with it for either a long or short time, but to the end of their days. And during this time, they're dependent not on infusions that they receive in the doctor's office, but on oral medication, which over the last 5 years has had an increasingly higher cost and require higher out-of-pocket costs than copays. This creates major challenges with respect to access to medication. In my practice, I primarily see lymphoma patients, but I have some myeloma patients. I had a patient whose out-of-pocket cost for his medication was $20,000 a month. He was not able to afford that, and my staff and our billing coordinators were able to work to get his copay assistance and get his costs down to something like $40 a month. But not all patients have access to that kind of infrastructure, and they're forced to make very challenging decisions about whether they take this medication, whether they're compliant with taking it every day, or whether they hoard their pills and take it on a less frequent basis. And we're seeing from Dr. Shamoun's study that these challenges are creating real differences in survival. As a society, we should strive to ensure that every patient, no matter what their socioeconomic status or their location, receives equal access to high-quality cancer care.
Thank you so much. And, you know, I think the take-home message from all these abstracts really is about access to care. You can't get care, you can't benefit from all the advances in cancer treatment that are being reported every year at the ASCO annual meeting.